Yeah. Present the case of a 9-year-old boy, second child of a non-consanguineous marriage, with a previously a strong family history of diabetes in the paternal side. Father was a young onset diabetes on he's on oral medications, and history of prior bronchial asthma, and he's occasionally on inhalers, and history of hyperpigmented patches in the upper limb, lower limb, and the trunk. It was earlier labeled as a lichenoid eruptions from 2019, and was initially on homeopathic treatment previously. Um, uh, he had initially presented in May 2021 in an outside hospital, and he was on follow-up from 3 endocrine centers from the period of May 2021 to May 2022 period. And this is the initial presentation in outside hospital initially. First, presented with the hyperosmotic symptoms, and that time he had a weight loss of around 8 kgs. From 40 kg, his weight has decreased to 32 kgs. And at that time, there is no abdominal pain, no decay at presentation. The fasting plasma glucose that is mentioned there was 277 and an HbA1c of 11.98 in the outside summary, with a fasting insulin of 2.57. The HOMO IR was 1.76, and the anti-CAD status was negative, and the anti-IA2 was also negative. But in summary, it was mentioned that since the patient had mild acanthosis and there's a strong family history of diabetes in the paternal side, they have labeled the patient as a probable type 2 diabetes and had started on glargine 7 units and a metformin twice a day. So after the May presentation in the first endocrine center, he had reviewed again with metformin and insulin in July 2021, and that time he had a weight gain of weight gain to 33.5 kg, and HbA1c had improved from initial 11.98 to 7.55. There is a C-peptide reading of 0.95 nanograms per deciliter, but we don't have a corresponding RBS during that time. Following this, the patient's insulin was stopped and he was continued on metformin. In October follow-up, he had a weight loss to 29.5 kg and his HbA1c was 9.7 during that visit, and he was restarted on glargine in October 2021. In November 2021 visit, there's a documentation of hypoglycemia with glargine, and following which he was shifted to aspart and metformin. The antibody status was again revalidated, and that is anti-GAD was negative, with anti-insulin antibody being negative, and the MODY genetic panel was sent. NG screening was done. It showed a heterozygous neuro D1 mutation in exon 2. In Jan 2022, in view of a suspicion of MODY, a trial of glimepiride was tried, and it was stopped after 1 month as there was a persistent hyperkalemia, hyperglycemia, and there is a flare-up in the skin lesions, and initially he had visited there, and the homeopathic treatment was started from outside center. In March 2022, during this period, the patient had a persistent hyperglycemic symptoms, and the patient was also erratic with the insulin and diet. And in March 2022, they had visited with the first DK, and there's also a documentation of sepsis was noted at the time. The HbA1c in that visit was 12.9, and he was on basal plus bolus insulin at the time of discharge. He was also initiated on prednisolone for the skin lesions, and he had continued the prednisolone from period of March to April end, tapered and stopped. By April, in view of his persistent hypoglycemic symptoms with periods of hypoglycemia in between, they had went for a CMC admission, and from there the patient was still continued on basal bolus insulin, and repeat insulin antibody testing was done, which was again negative. Pediatric dermatology department they had visited, and at that time the skin biopsy was done, which showed a lichenoid dermatitis, and the patient was started on acitretin, and tacrolimus topical ointment was also initiated. He was continued with the injection aspart and glargine during this period post discharge from CMC. And from 30th of April, he had there was repeated episodes of hypoglycemia that is not related to any meal timings, and there is a gross fluctuation between hypoglycemic and hypoglycemic events. GRBS as low as 33 and as high as 44 was documented. And he had persistent neuroglycopenic symptoms even at presentation, but no history of any seizures. In view of this persistent hypoglycemic symptoms, the patient has stopped all insulin for a period of around 2 weeks prior to presentation in our hospital. And the OPD visit, he had first time visited our OPD on May 2022, and this is the history from our hospital. Antenatally, the mother had a GDM, and there is also a history of hypothyroidism. The birth history, the birth weight was 3.1 kg, normal delivery, term delivery. He had a delayed cry at birth, but postnatal period, there is no history of any hypoglycemia, no prolonged jaundice. He has a very erratic diet. He has snacks in the middle of the night, and also high calorie carbohydrate diet he usually follows. Developmentally, academically normal, academically good, and no developmental delay as such. Family history, the father had a history of diabetes at 35 years of age, and he was on OADs. Father's parents is a paternal grandfather was 40 diabetes at 47 years of age and was on OADs. Grandmother was a diabetic at 50 years and on OADs. Paternal siblings and aunts, no other issues of diabetes in the family. Maternal grandparents, the grandmother was diabetic at the age of 40 years. On general physical examination, his weight was 35.3, 50th to 75th centile, and a height of 133 centimeter, 10 to 25th centile, and the mid-parental height of 165 centimeter. His 10 to 25th centile. Pulse rate 94, BP at 110/60, and respiratory rate of 22 per minute with no features of any dysmorphism. On skin lesion wise, there's extensive skin lesions noted, thickened and generalized scaly hyperpigmented pruritic lesions over the legs, arms, forearm, and hyperpigmented papules are also noted. Similar papules are also seen in the trunk and the back area. There's a mild acanthosis, grade 2, and SMR was normal. As other systemic examination was normal, and fundus examination was also normal. During the initial OPD visit, since the patient was on astatinin 10 mg once daily, the hypoglycemia was attributed to the same initially. Following which the acetretin was stopped, and he was planned for an admission after a few days. So during this period, the patient's frequency of hypoglycemia had decreased following the discontinuation of acetretin, and the mother, since the sugars were still on the higher side, mother had reinitiated the patient on aspart and glargine. The patient started developing episodes of hypoglycemia with small doses itself, and then the patient presented the casualty with neuroglycopenic symptoms. So prior to the presentation to the ER, it was noticed that the last dose of insulin glargine was taken 48 hours prior to the presentation. In the casualty, he was noted to have neuroglycopenic symptoms, and in view of that, critical samples were taken. And following which, it was noted that serum insulin level for an RBS value of 67, the serum insulin was 12 micro IU per ml, and the C-peptide value of 0.29 nanogram per ml. And he was admitted from the ER, and following which he had food in the ward, but in spite of that, his sugar reading after reaching the ward also was on the lower side, following which critical samples were taken. Now, his random venous plasma glucose was 39.2 and a C-peptide of 0.072 nanogram per ml, and serum insulin level of 4.5 micro IU per ml. In view of a suspicion of an exogenous insulin administration, patient was strictly monitored for any exogenous insulin administration, and it was every insulin administration was supervised following the visit. This is during the IP stay. The patient had a last prior to the IP stay, the last dose of insulin glargine he had received 48 hours prior to the admission. This was the casualty value of 67, following which the RBS values and C-peptide was noted. And the critical sample of 39.2 RBS, we had taken the samples showing a C-peptide of 0.072 and serum insulin level of 4.5 micro IU per ml. It is also to be noted that following a sugar reading of 523, aspart 1 unit was given, and following is the sugars again dropped to 45 during the IP stay. The third sample of for an RBS of 506 is the last value. A C-peptide of 0.773 is also done during the hospital visit. These are the summary of the important labs of this patient during the visit. The insulin antibody was just positive, 35.19, 0 to 20 was the cutoff. The anti-TPO was negative, the life status was normal. The anti-GAD and IA2 done outside was negative. The USG abdomen done was normal, and serum amylase lipase were normal, and cortisol axis and the celiac screening done was normal. And also the patient was also shown in a CT abdomen at a later stage, and normally visualized pancreas in that. Just summarizing the C-peptide and the random blood glucose readings also. Since we had a disparity, so just mentioning again, the ER presentation, the blood glucose value of 67 was noted, and the C-peptide 0.29, and the serum insulin levels of 12 was there, and the critical value and the critical sample also, the C-peptide was 0.072 for an RBS of 39, and insulin level was 4.5 micro IU per ml. We had an initial suspicion whether there's any cross interaction, so we had discussed with the lab, and our lab, based on the assay, we had discussed with the lab, and usually analog insulin, they doesn't pick up Lispro as part in different concentration they have tested, and in all that, usually it is not supposed to pick up in the current assay, but we had tested with two separate patients, both of them. Post meals, they had shown that the assay had picked up some analog insulin, both aspart insulin of 6.8 that pick up 2 hours after meal. This is all postprandial values, and in both the samples, the insulin levels were detectable. Continuing the IP stay, due to the IP stay, the patient's periods of hyperglycemia was persistent, and during the episodes of hyperglycemia, there was a mild ketosis also noted during the hospital stay. This patient had gross fluctuations during this period, and he was in view of this hyperglycemia, is managed with IV dextrose fluids during the IP stay, and following this, the glycemic status stabilized during the stay in the hospital. He was discharged on aspart 3313 and the glargine of 10 units. But even at the time of discharges, sugar readings were persistently fluctuating at home. This is the GRBS readings that's done at home. And there was a gross fluctuation even with minor doses of insulin administration. The sugar values occasionally were more than 700. And with minor insulin administration, there was a drop to less than hundreds. The patient was readmitted in view of his glycemic variability, and again he was shifted to a Lispro so that we can administer at 0.5 units and a Lantus of 2 units at night, and the patient was discharged on CGMS. But even with the minimal doses of insulin administration, the patient demonstrated hypoglycemia during this period. This CGMS reading is taken 10 days after the second discharge. 1 unit of Lispro was given in the afternoon, and following this, the patient had 3 episodes of hypoglycemia without administration of any other insulin during this period. And the last one being even after 24 hours, there's a persistent hypoglycemia that's occurring in this patient. Coming to the final genetic report of this patient, earlier genetic report done from the outside center had shown a NGS positivity of neuro D1, and this familial screening was also done during this time, and it has shown that the father, who is a young onset diabetic, was negative for this variant, and the mother and the other 2 sisters of this patient was found to be carriers, but they did not have any other manifestations as such. So the mother was a GDM during the pregnancy period. Coming to the diagnosis of this patient, we are not very clear about the diagnosis of this patient. It's just assuming to be a young onset diabetes, query type, probably type 1B diabetes or a MODY type 6. And the cause of this brittle diabetes can be like a exogenous insulin or insulin dysregulation or insulin autoimmune syndrome. We are not very clear.